Okay.
Okay. Good afternoon, dear delegates, for the webinar sponsored by Panacea Biotech on approach to neonatal cholestasis. Neonatal cholestasis is important to manage for pediatricians and hepatologists. It is very important the early diagnosis which is getting missed out. Therefore, the role of pediatrician is very important to diagnose and refer to the tertiary care centers. Indian Association of Pediatricians has formed the guidelines and recommended that the referral of neonatal cholestasis cases to tertiary care centers with the expert unit of the gastroenterology, importantly pediatric hepatology, must have to be present to manage such cases. For this, we have Dr. Vikrant Sood, who is going to moderate this session. Dr. Vikrant Sood is MD Pediatrics and DM Pediatric Hepatology. He is currently Assistant Professor at Institute of Liver and Biliary Science, New Delhi. He is involved into the various clinical research, and credit to it, he is having the more than 50 publications to his repute, which is very well recognized and awarded. I request Dr. Vikrant Sood to moderate and take the question and answer session at the end and introduce our today's speaker, Dr. Rajiv Khanna. Over to Dr. Vikrant Sood.
Thank you, Dr. Kunal. A very good afternoon to all the viewers. It's my proud privilege to introduce my senior faculty, Dr. Rajiv Khanna, who is currently working as an additional professor in the Department of Pediatric Hepatology at the Institute of Liver and Biliary Sciences. He had, I think, he doesn't need any more introduction, but in brief, I can say that he had the privilege of getting trained at the most prestigious institutes in the world. That included SGPGI Lucknow, followed by his stint in King's College Hospital, London. And his main research interest, as we all know, has been in neonatal cholestasis and pediatric portal hypertension. And today he's going to present a brief approach to neonatal cholestasis, which would be a case-based scenario approach. The cases have been picked up from the common scenarios that we face in our pediatric liver practice. And I think it would be very beneficial to all pediatricians, neonatologists, and including the budding pediatric gastroenterologists who are managing these cases in their private practice or government practice. So I think I'll hand over to Dr. Rajiv Khanna to go ahead with the presentation.
Good afternoon, everyone, and thanks Vikrant for the introduction, and thanks to Panacea Biotech for organizing these seminars, these webinars in pediatric liver topics. So without wasting any time, I will start this talk on approach to neonatal cholestasis. So I will give my talk under these headings. So what is the terminology which we should use? The neonatal cholestasis or conjugated hyperbilirubinemia, and when should we call infantile liver failure? And what are the common etiologies? Biliary atresia, other etiologies like metabolic, cholestatic versus other etiologies, and how to differentiate. And I will cover my talk with common case scenarios, and in the end I will give some key learning points. So what is neonatal cholestasis, or should we call this conjugated hyperbilirubinemia? So the definition is when the direct bilirubin exceeds 1 milligram per deciliter, it needs evaluation. Whereas the older definition was when the direct bilirubin was 20% of the total bilirubin, so then it is called neonatal cholestasis in infants under 6 months of age. And when this bilirubin crosses 2 weeks of life, because some of life, there may be some physiological cholestasis. So any direct bilirubin which is more than 1 milligram per deciliter beyond 2 weeks of life is called conjugated hyperbilirubinemia, and it is preferable to use conjugated hyperbilirubinemia as a terminology rather than cholestasis, because cholestasis signifies a physiological, biochemical and a pathological term, whereas conjugated hyperbilirubinemia is actually should actually be the terminology which should be used, and it encompasses all the causes of under this broad group. And prevalence wise, it affects 1 in 2,500 infants, so it is not that less common. So if we see the spectrum of neonatal cholestasis, so in this presentation we will continue to use the term neonatal cholestasis, which we define under 6 months of age. So rather than conjugated hyperbilirubinemia. So if we see this diagram, there is a slide, but this shows that there has been a change in the spectrum of neonatal cholestasis over 4 decades. So in the first 3 decades, from 1970 to 2000, idiopathic neonatal hepatitis comprises more than 50% of the cases. But beyond 2005, over last 10-15 years, so many more etiologies are coming into picture, like PFICs 1, 2, and 3, and there are many more PFICs which are now coming, Alagille syndrome, bile acid synthetic defects, and many more metabolic disorders. So this idiopathic neonatal hepatitis group is shrinking, and it is hardly 12 to 15% now. So if we look up our own data over 8 years from ILBS, so 265 neonatal cholestasis under 6 months of age, the commonest etiology still is biliary atresia, around 46%, and followed by PFICs around 11%, followed by metabolic liver disorders, galactosemia, tyrosinemia, mitochondriopathy, and infections like CMV, sepsis, urinary tract infection, and a small proportion comprised by multifactorial causes, that is a combination of prematurity, sepsis, TPN usage, or necrotizing enterocolitis, and then around 6% may be paucity of bile ducts, which may be syndromic, that is Alagille syndrome, or non-syndromic. Then a small proportion is constituted by other insignificant causes like hemophagocytosis, sometimes presents as neonatal cholestasis, congenital congestive hepatopathy, hypothyroidism, neonatal sclerosing cholangitis, congenital portosystemic shunt, inspissated bile duct syndrome, or transient myeloproliferative states. So if we can see our own data, so idiopathic neonatal hepatitis comprises just 10.2% of the total causes of neonatal cholestasis. So coming to the case 1, so this was a 56-day-old boy who was a full-term delivery, good birth weight, who presented with jaundice since day 20 of life, with dark urine and acholic stool. So we can see there was diaper staining and the stool which was totally pale. So, and he also had history of skin bleeds, and the skin bleeds responded very well to injection of vitamin K. So there was no history of fever, seizures, altered sensorium, vomitings, poor feeding, lethargy, failure to thrive, or developmental delay. Antenatal period was immunity, and other 2 steps were healthy. So the key points in history in this particular case, so he had definitely conjugated jaundice indicated by dark urine and acholic stools. There were mucocutaneous bleeds which indicate vitamin K deficiency. So growth is important in all cholestatic infants. So his growth was almost normal, as we can see his in his anthropometry. Then perinatal events, so there were no adverse perinatal events. So we should ask for gestational age, birth weight, TPN usage, meconium ileus, or sepsis, and some of these things we will see in the subsequent cases. So on examination, the weight and hair height centers were normal. There was mild pallor, icterus. There were no peripheral of chronic liver disease. And if we see this stool chart, so the stools were acholic. So this stool chart is being used by most of the pediatric hepatology centers. We are also using, so just to see the stool color by naked eye and comparing with this stool chart. So definitely acholic. And per abdomen examination, liver was 4 cm below costal margin, firm in consistency, and spleen was 3 cm below costal margin. There was no free fluid. So the key points in examination in this particular case, the anthropometry was normal, and 3 different stool samples, so they were all acholic, skin bleeds were there. We should always look for associated congenital defects like situs inversus, dextrocardia, and look for the consistency of liver and presence of spleen. If we come to the investigations, we can see here that the INR high initially, but just with a single dose of vitamin K, it got corrected from 5.7 it became 1.2. His bilirubin was high, which indicate conjugated hyperbilirubinemia, as we can see by the fraction of the direct bilirubin. The cholestatic enzymes were much higher than the transaminases, and there was high GGT. So GGT was 342. So the synthetic functions of the liver indicated by albumin and INR, they were normal. So synthetic functions were preserved. So what should we look for on ultrasound in these cholestatic infants? On ultrasound, we should first of all look for the presence of gallbladder. If the gallbladder is absent, then that indicate biliary atresia, and if the gallbladder is visible, then we should ask the radiologist to look for the size of the gallbladder. If it is less than 20 mm or less than 15 mm, then it may be a suggestion. Then contractility of the gallbladder, presence of triangular cord sign, which is an area of echogenicity just at the level of bifurcation of portal vein. So this is a triangular cord sign, which is shown here in this picture. Then subcapsular flow just beneath the capsule of the liver if there is increased blood flow, and also prominence of hepatic artery. So these are certain signs which we should ask our radiologists to look for in cholestatic infants. Then also we may sometimes miss choledochal cysts. So if the CBD is visible, we should ask for the diameter of CBD. If it is more than 1.5 mm in a newborn, it may indicate choledochal cyst, or if it is more than 3 mm in older infants, then it may be a suggestion. So now, what is the role of HIDA scan in evaluation of cholestatic infants? So first of all, the HIDA scans should be done after priming with phenobarbital or ursodeoxycholic acid for 3 days. So these two drugs may help in improving the biliary excretion and improve the sensitivity of the HIDA. But when is HIDA indicated? That is still a question. So what you are seeing with your naked eye, that HIDA will only tell. So acholic stools seen by naked eye are equally informative as a non-excretory HIDA. So HIDA scan is only indicated when the stool color is fluctuating, just to exclude biliary atresia. So does this infant need to be investigated for these things like CMV, metabolic, thyroid profile, or tender mass spectrometry? So this is a clear-cut case of with acholic stools, jaundice, and firm liver, spleen. So this is a clear-cut case which may indicate biliary atresia. So these tests are not indicated in this particular infant. What is the role of liver biopsy? Definitely liver biopsy is indicated because it has 95% accuracy for biliary atresia, and early liver biopsy should be done just to refer these patients for Kasai portoenterostomy. So what are the findings we should look for? So we should look for portal tract expansion with broad fibrosis, bile ductal proliferation, and presence of bile plaque. So these are the pointers which should be seen in the liver biopsy, as seen in this picture, that the portal tracts in the lower in panel B, we can see the portal tracts are expanded, and within the portal tracts there are prominent bile ductules. So bile ductal proliferation is there. So biliary atresia, as we all know, is a progressive obliterative disease of the intra and extrahepatic bile ducts of infants and affects 1 in 12,000 live births. And this is the commonest cause of neonatal cholestasis and is the commonest indication for liver transplantation in children. So there are 3 types of biliary atresia depending on the level where the atresia is starting. If it is starting below the opening of the cystic duct, so then it is type 1. If it is above the opening of the cystic duct but the porta is spared, so then it is type 2. But unfortunately, involvement of the porta is the commonest type, that is type 3 biliary atresia. So the surgical option is when the artery is atretic. So this is replaced by a jejunal loop of around 40 centimeter, and the porta is dissected, and this loop is connected directly to the porta. So this is Kasai portoenterostomy. So, but unfortunately, around 30 to 40% of times, so this may fail. So eventually, these children may ultimately need liver transplantation. So this is the flow chart for evolution of cholestatic infants. So if a baby has neonatal cholestasis, as per definition, if we have defined cholestasis, so we should immediately give him 1 dose of vitamin K, and we should look for LFT, check 3 consecutive stool specimens. So there are different colors of stools which you may see, but all of these have different shades of yellow. So these stool colors are of different babies. 2 are biliary atresia, 1 again which was acholic was paucity of bile ducts, 1 has TPN cholestasis, 1 had idiopathic hepatitis, and 1 was premature. So we should always remember to look for at least 3 different stool specimens to look for the stool color. So after seeing the stool color, we should differentiate whether this is acholic or fluctuating stool color or pigmented stools. If it is acholic, we should immediately look for ultrasound in a fasting state to look for whether the gallbladder is absent, or if it is a small or abnormal gallbladder, then it may be biliary atresia. So a biopsy should be done. to confirm the diagnosis, and then followed by early referral for Kasai potentoscopy. And sometimes the ultrasound may also pick up choledochal cyst. Again, these babies may require early surgery. If the baby has pigmented stools on the right hand side of the chart, if the baby is well, this may be indicative of that he may have prematurity, or he may have adverse perinatal events, TPN usage, or this baby may be just having PFIC. If the baby is sick, first and foremost thing is we should rule out infections, sepsis, urinary tract infection. If the baby is having synthetic dysfunction in the form of deranged INR, low albumin, then these are pointed towards metabolic liver diseases like galactosemia, tyrosinemia, or mitochondriopathy. So these are the common disorders which we should always remember. In specific situations only, we should do CMV, testing for HSV, ferritin, alpha-fetoprotein, or urinary succinylacetone. Now coming to case 2. So this was a 1-month-old boy who presented, who was term normal vaginal delivery with a birth weight of 3.1 kg. He had progressive jaundice right from first week of life with pigmented stools, and he had episode of sepsis, fever, lethargy, refusal to feed at around 1 month of age. He had progressive abdominal distension. There was no history of added sugar intake, no hypoglycemia, seizures, no diarrhea, vomiting, no fever or bleeding from any side. So there was history of consanguinity, but no history of any intrahepatic cholestasis of pregnancy, no history of pregnancy-induced hypertension or oligohydramnios. So he had significant failure to thrive. He was sick, inconsolable cry, icterus with encephalopathy, and on per-abdomen examination, which abdomen was distended with hepatomegaly, and spleen was also there, ascites was present. So investigation, if we see here, so the hemoglobin was 12.2, but this was after a blood transfusion. Bilirubin there was definitely conjugated hyperbilirubinemia. Transaminases were elevated, and if we can see here, in contrast to the previous infant, so this baby had synthetic liver dysfunction in the form of low albumin and high INR. So ultrasound showed coarse ecotexture of the liver, which indicate that the liver is going towards cirrhosis. So subsequently, if we make up the syndromic diagnosis of this infant, so this was a sick infant with jaundice and pigmented stool. So this was an intrahepatic cause of cholestasis rather than extrahepatic. So if the stools are pigmented, so you can and if you have seen the stools by your naked eyes, so you can yourself say that possibly this is not biliary atresia. And he had some other features also, like he had ascites. On investigation, he had hyperbilirubinemia, coagulopathy, so there was synthetic dysfunction, which usually does not happen very early in the course of in the natural history of biliary atresia. So this baby had synthetic dysfunction, which is a pointer towards metabolic liver disease. So always we should look for pointers of metabolic liver disease in the family, like history of consanguinity, recurrent abortion, SIP deaths, diarrhea, vomitings, lethargy, or seizures. So this was a 1-month-old baby, progressive jaundice, pigmented stool. Subsequently, he was also found to have cataract, and he had early decomposition, fulminant course. There was a family history and coagulopathy. So this was a baby who was sick. So should we call this infantile or neonatal liver failure? So what is a better term? So neonatal liver failure is defined as failure of the synthetic dysfunctions of liver within 4 weeks of life. So with an INR, so this is defined as when INR is more than 2, or some of the experts say that the INR should be more than 3. So encephalopathy or term acute or exclusion of chronic liver disease. So these terms are not used in this definition, because these terms may be fallacious or difficult to define or difficult to appreciate. So just neonatal liver failure or infantile liver failure is used in this particular age group. So what are the etiologies which we should look for? So first and the foremost are metabolic liver diseases, because the presentation was around 1 month, galactosemia, tyrosinemia, or mitochondriopathy. Then immune disorders like gestational alloimmune liver disease, which was earlier known as neonatal hemochromatosis. So metabolic and neonatal hemochromatosis should definitely come into picture. Then infective causes like HSV hepatitis or sepsis or urinary tract infection. Then other causes like genetic cholestatic disorders like PFIC type 2, which sometimes can present very early with liver failure, or some of its variants like FXR mutation, TJP2 mutation, or bile acid synthetic defects. can present as infantile liver failure. Then lastly, storage or infiltrative disorders like Wolman or Niemann-Pick type C and HLH. So these disorders can also present as infantile liver failure. So how to differentiate these groups of disorders? The first in this table, the first column is of neonatal hemochromatosis or gestational alloimmune liver disease. Second is herpes. Third is hemophagocytosis, and lastly is metabolic. So to differentiate is bilirubin may not actually differentiate, but for metabolic liver diseases and HLH, the bilirubin levels may not be very high. Transaminases are usually very high in herpes-related liver failure, where the presentation is within first week of life. Whereas in neonatal hemochromatosis, the transaminases are usually normal or low because it is just a burnt out disease. The babies usually present with antenatal cirrhosis. Similarly, in HLH and metabolic, the transaminases may be mild to moderately elevated. Regarding coagulopathy, the coagulopathy will be very severe in neonatal hemochromatosis and moderately severe in metabolic liver diseases, whereas not that it will be just mild in HLH. Cytopenias will be there in HLH and also in herpes when there is multi-organ dysfunction associated with the herpes-related liver failure. Lastly, about ferritin. So ferritin levels will be high in neonatal hemochromatosis and in hemophagocytosis. So these are the 5 tests like bilirubin, transaminases, coagulopathy, cytopenias, and ferritin, which can help in differentiating the various causes of neonatal or infantile liver failure. So what are the pointers for metabolic liver disease? So these are this box shows various pointers, like in the family history we should look for neonatal deaths or miscarriages, consanguinity, and the pattern of the liver disease, whether it is autosomal recessive or X-linked, that can point towards specific disorders, whether there is any history of acute fatty liver of pregnancy or HELLP syndrome in the mother, which can point towards fatty acid oxidation defects. If there are recurrences in the food avoids like sugars, so that may be a pointer towards high fructose intolerance. Then diarrhea and vomitings, again a pointer towards fructose intolerance and galactosemia. Then failure to thrive and intractable rickets, if it is there, so then that may point towards tyrosinemia. Specific orders like boiled cabbage order, so that is again a pointer towards tyrosinemia. If the disease is multisystemic, so then like renal, cardiac, CNS, bone marrow, muscle, or GI involvement, then that is a pointer towards mitochondrial hepatopathies. Also, we should look for if there is discrepancy between the synthetic functions of the liver and the secretory functions of the liver. Synthetic functions means albumin and INR, and secretory functions means bilirubin. So if there is discrepancy and synthetic functions are more compromised, so then that is a pointer towards metabolic liver disease. So how to proceed? So urine NGRS, non-glucose reducing substance, using a Benedict's test, which can be done at the bedside to look for the presence of reducing sugar, and using a glucose strip also. That is, it is a non-glucose reducing substance. So the Benedict's test should be positive, and on glucose strip the glucose is not positive. So non-glucose reducing substances, if they are positive, so then that may be a pointer towards galactosemia. So GALT assist should be done. For other metabolic workup, alpha-fetoprotein, if it is more than 1 lakh, so then we should look for a confirmatory test, that is urinary succinylacetone. Other tests like ferritin, fibrinogen, TMS, or CMV, HSV, so they are indicated only in specific scenarios. Clinical presentation of galactosemia. So this is a study from SGPGI Lucknow, where it is mentioned that around half of the cases have cataract, they present with ascites and lethargy, and almost all of the cases have hepatosplenomegaly. A proportion of cases may have consanguinity or SIP death and hemolysis, and around 60 to 70% have laboratory abnormalities in the form of hypoglycemia and uncorrected coagulopathy. So now coming to scenario 3. So this is a boy who presented at around 60 days of age, and this was a preterm 28-weeker quadruplet cesarean born and birth weight of 1.08 kg. He cried immediately. There was no birth asphyxia, but subsequently he had respiratory distress syndrome, required surfactant and positive pressure ventilation, followed by CPAP, which he required for 1 month. And he had an episode of necrotizing enterocolitis, but he did not require any surgery. But he remained on total parenteral nutrition for around 5 weeks. And also he had sepsis screened positive in the form of Acinetobacter and Candida. So his enteral feeding was initiated after the 5 weeks of life, EBM and formula feeds, and he had progressive failure to thrive, and then subsequently had jaundice, which was progressive. Initial stools were pigmented, but subsequently they become acholic. Cholestasis, bleeds, seizures, ultrasensorium, or fever. So on examination, he was pale, icteric, without any features of chronic liver disease. So his nasal septum was atrophic because of the usage of CPAP. And per abdomen examination, liver was 2 centimeters soft and spleen was 1 centimeter below costal margin and without any free fluid in the abdomen. CBS and CNS examinations were normal. So this was the stool color, which was completely acholic. So on investigations, we can see here the bilirubin was on rising trend with direct hyperbilirubinemia, and EST-LT were elevated, alkaline phosphatase was very high, and GGT was almost normal, and albumin was low, which we can interpret as it may be nutritional, and INR was 1.37, which was normal. So ultrasound showed a normal size gallbladder 22 mm, and there was no triangular cord sign. Subsequent workup was done, which showed a normal thyroid profile, normal X-ray dorsal spine, and ophthalmological examination. Echo was normal. So the paucity of bile duct, that is syndromic paucity or Alagille syndrome, was unlikely because these tests were normal. So metabolic screen was done, which showed urine and GRS positive, alpha fetoprotein of 2.37 lakh, and lactate was normal. There was no acidosis, and there was mild just hypoglycemia. That's why this evaluation was done, and subsequently his GALT came out to be normal, and urinary succinyl acetone was negative. His sepsis screen grew Klebsiella and urine in the blood, and urine culture was negative. So to summarize, this baby was premature, appropriate for gestational age, required TPN for 5 weeks, and subsequently had failure to thrive, progressive jaundice, and initially had pigmented stools which became acholic, but subsequently with conservative management and improvement of nutrition, giving ursodeoxycholic acid and control of sepsis and nutritional rehabilitation, his jaundice improved. So the etiology in this particular case was multifactorial, related to prematurity, TPN usage, sepsis, and NEC. But however, in all these children, we should carefully look for whether the child is also having biliary atresia or paucity of bile ducts or PFIC. So next scenario was baby. So this was a 9-month-old infant. I have included this infant in this presentation, although he was 9 months, because some of these babies whom we call as neonatal cholestasis but actually present late. So this baby has a presentation right from birth, right from first month of life. He had jaundice and presented at 9 months at 9 months of age with progressive with low grade jaundice. And subsequently, from 6 months of age, he had severe excruciating pruritus, and also he had skin and nasal bleeds for which he required 1 blood transfusion, and he also had greasy and foul-smelling stools. So, on further histories, so he was a normal vaginal delivery. There were no perinatal complaints. Weight was 3 kg. There was no history of clay-colored stools, seizures, altered sensorium, developmental delay, abdominal distension, or irritability. So, in antenatal history, there was a significant history of pruritus in the last trimester of pregnancy, which started around 28 weeks of gestation, and it resolved completely after the delivery. So that was a typical history of intrahepatic cholestasis of pregnancy. So there was no history of jaundice in the mother, or fever, rash, or any lymphadenopathy, and no consanguinity. This was the first child, no abortions. On examination, his growth centiles were severely affected, less than 5th centile. Pallor was there, icterus was present, and he had the vitamin A deficiency in the form of bilateral white spots and conjunctival xerosis, but no other peripheral stigmata of chronic liver disease. Stools were pigmented, and on per abdomen examination, his liver was 4 cm below costal margin, which was soft, and spleen 3 cm below costal margin without any free fluid. So this was a baby with infantile cholestasis, pigmented stools, pruritus, and fat-soluble vitamin K deficiencies A and K, growth retardation, anemia, and history of antenatal pruritus. So all of these features point towards that this baby had this cholestatic liver disease of infancy, which was most likely to be progressive familial intrahepatic cholestasis, either type 1 or type 2. So when we look up the indications, so we can see here he was anemic. Bilirubin was mildly elevated 4.59, and but this was definitely conjugated hyperbilirubinemia. Transaminases were not that high. Alkaline phosphatase was 264, and if you can see his GGT was just 21, and synthetic functions were normal, INR 1.1 and albumin of 3.7. So in the liver biopsy, so there was cirrhosis, which has already set in. There were features of cholestasis in the biopsy, hepatocellular and canaliculaar cholestasis, rosette formation, and very mild inflammation. So the possibility of PFIC, either type 1 or type 2, was kept. So how should this, so GGT has an important place in the evaluation of cholestatic disorders. So on the basis of the GGT, whether it is low GGT cholestasis or high GGT cholestasis, we can differentiate certain disorders, like in the low GGT group, PFIC type 1 and type 2 come. So type 2 is the BSAP deficiency, bile salt export pump deficiency, and certain related disorders which are also called now as PFIC type 4 and type 5. So tight junction protein 2 mutations and personoid X receptor mutations, which are known as the more severe forms of PFIC, and also biosynthetic defects and Agonese syndrome. So these all disorders come into the low GGT cholestasis. Then into the high GGT cholestasis come Alagille syndrome, PFIC type 3 or MDR3 deficiency, neonatal sclerosing cholangitis, inspissated bile duct syndrome, and also cystic fibrosis related liver disease. This is the big diagram which shows the different transport defects and how they and which transport proteins which they actually transport. So this is the here in the diagram we can see the hepatocyte with the canalicular side of the hepatocyte, canalicular membrane of the hepatocyte, which has these transporters. So the PFIC type 1 which transports aminophospholipid, type 2 which transports bile salts, and type 3 which transports phosphatidyl choline. These disorders can be differentiated on clinically as well as on the basis of some of the laboratory tests and also on their natural history. So of these three common disorders, two of these can present as in the early infancy as neonatal cholestasis with low GGT, but PFIC type 1 has a slow progression, and whereas PFIC type 2 may progress rapidly. In PFIC type 1, there is more of growth failure, short stature. There may be extrahepatic features like diarrhea, pancreatitis, and deafness, whereas in type 2, the other extrahepatic features are absent. Both have low GGT cholestasis, and the progression, as I said, is rapid in type 2, so they may progress towards cirrhosis by 2-3 years of life. On the other hand, PFIC type 3 has a slow progression. So these children usually present later in the childhood or adolescence as cirrhosis and portal hypertension, and they have high GGT cholestasis. So summarizing, so there are different pointers in the etiology of neonatal cholestasis. So like we should remember seeing acholic stools, but there are other differentials of acholic stools apart from biliary atresia, like neonatal sclerosing cholangitis. Sometimes the babies may have spontaneous perforation of bile duct or paucity of interlobular bile ducts, and which constitutes Alagille syndrome. If the baby is sick, has liver failure-like picture, then galactosemia, sepsis, UTI, neonatal hemochromatosis, or herpes, so these should be considered. And if this is a typical liver failure-like presentation, then definitely galactosemia and neonatal hemochromatosis should come. Then we should always look for eye findings like cataract, galactosemia, which is seen in galactosemia and rubella, posterior ambryotoxin for Alagilles, chorioretinitis in torch infections, and cherry red spot for Niemann-Pick type C. If the baby is preterm or IUGR, so then again this may be pointed towards neonatal hemochromatosis or torch infections. Dysmorphism, if it is there, then Alagilles or Down syndrome related cholestasis. Then microcephaly with calcifications, CMV, macrocephaly, toxoplasmosis, and if there are petechiae or blueberry muffin spots, again torch infections. If there is hypoglycemia or refractory hypoglycemia, then galactosemia, neonatal hemochromatosis, mitochondrial hepatopathy, and tyrosinemia. If there are seizures, then galactosemia and mitochondrial hepatopathies. If there is developmental delay, then galactosemia and mitochondrial hepatopathies. If there is abnormal order, then tyrosinemia. Other pointers are like vertebral and cardiac defects are seen in Alagille syndrome. Cardiac defects are also seen in association with biliary atresia or in congenital rubella. GCT we already discussed. Pruritus, apart from PFIC, it is also seen in Alagille syndrome, which is a disorder of high GCT cholestasis, and other disorders where pruritus may be seen are neonatal sclerosing cholangitis or late forms of biliary atresia. Then alpha fetoprotein, if it is more than 1 lakh, then this is seen in anemia and in neonatal hemochromatosis. If it is more than 1000, so then it is a pointer towards hemochromatosis or hemophagocytosis. Cytopenias, if they are there, so then hemophagocytosis, or it may be seen with the herpes when it is associated with multi-organ failure. Urinary non-glucose reducing substances we already discussed, and ultrasound findings we already discussed. So take-home messages for evaluation of cholestatic infants are, so when you see jaundice during neonatal period or infancy, we should always look for stool color and urine color. Urine color will indicate whether this is conjugated jaundice, and stool color will indicate whether you are dealing with an obstructive cause like biliary atresia or choledochal cyst. We should always do conjugated fraction of bilirubin in order to fulfill the definition of neonatal cholestasis or conjugated hyperbilirubinemia of infancy. And first thing is we should give two doses of injection vitamin K, and look for specific pointers, etiological pointers in the history, examination, and also in the basic laboratory investigations. Ultrasound should be done by a trained radiologist, and biopsy is indicated particularly when you are suspecting biliary atresia, for early intervention and early referral for Kasai hypotentrostomy. If the baby is sick, we should always look for sepsis, urinary tract infection, and if there is significant coagulopathy, we should look for metabolic disorders like galactosemia, tyrosinemia, neonatal hemochromatosis, or herpes. Thank you everyone for kind listening, and stay safe.
Thank you, sir, for the lucid presentation. I don't see any questions which have been put up in the forum as of now. Sir, if we talk about the benefits of pediatricians or people who are not working primarily in pediatric gastroenterology or hepatology, in your practice, what are the five most common causes of neonatal cholestasis which you would see, and what should be the most common that we think of in our routine clinical practice?
That is very important question, Vikrant. So as I have seen, what we have actually done in our profile of cases at ILBS, so the commonest etiology is still, means in our setup in our country, the commonest etiology which we should never miss and which is still the commonest cause is biliary atresia. That is the structural causes, biliary atresia, and followed by what we are seeing is progressive familial intrahepatic cholestasis. So PFIC is the another big group which we are seeing. So as we can see here, again the common etiologies, the structural causes, it is predominantly biliary atresia. Rarely we have seen choledochal cyst presenting as neonatal cholestasis. And the second commonest etiology is progressive familial intrahepatic cholestasis, and out of these the PFIC type 2 is the commonest which we are now picking up. And if the presentation is like more of synthetic dysfunction, that is what we can also call as neonatal or infantile liver failure, so then the common causes which we see are galactosemia and tyrosinemia. Then the other causes are constituted like multifactorial and infection, so they also come in picture. And a small group like 6% what is mentioned, and this group also should not be missed, is paucity of intralobar bile ducts, which can almost resemble biliary atresia. So these babies with paucity of intralobar bile ducts, means their extrahepatic ducts are normally formed, but intrahepatic, if we do the liver biopsy, the number of ducts in comparison to the portal tracts are less. So paucity of interlobular ducts, which is the common, and among this the commonest etiology is Alagille syndrome. So this disorder we should also not miss, and we should look for the pointers of Alagille syndrome. And sometimes there is misdiagnosis of biliary atresia in cases of Alagille syndrome. So I can broadly say that these are the common causes: biliary atresia, PFIC, the metabolic group, and the paucity of interlobar bile ducts. And also sometimes we see multifactorial causes which are treated at other centers and subsequently present to us with jaundice, but they have a resolving jaundice-like picture. They may have suffered from prematurity, sepsis, TPN usage, and so this is a group which is called as multifactorial etiology of neonatal cholestasis.
Thank you, sir. So now we see many questions have started trickling in. First question is from Dr. Neeraj. His question is it possible to have pigmented stools in the first few days of life in a newborn with biliary atresia?
Actually, this is a good question, because what in our experience, what we have seen in most of the babies, what we get the history in biliary atresia infants, that first 2-3 days they pass normal meconium. So meconium is normally passed, and then subsequently with the normal and after 2-3 days of life, the stool which come out is like a totally acolic stool. So that is the usual history which we get, but in the text it is even described, the what has been described as two forms of biliary atresia. So one is an embryonal or a fetal form of biliary atresia, and other is a perinatal form of biliary atresia. So embryonal form, so there is a debate now people say that all biliary atresia are actually they are actually formed in the intrauterine life, but still in the textbooks it is mentioned that embryonal or the fetal form of biliary atresia is around 20-25%, and the remaining all is perinatal. So theoretically perinatal forms may present by around 2 weeks of life, 2 weeks of life with acolic stools. But in our experience, most of these babies have acolic stools right from first week of life.
So second question is from Dr. Vineet Kumar Kumar. He asked that up to what age we can call it as neonatal cholestasis?
That also is interesting. Means the neonatal cholestasis system, what has been defined like from the ISGAN, the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition. So they also say that up to 6 months of age we should call it as neonatal cholestasis. But I already discussed in my first slide that there is a controversy in using the term neonatal cholestasis or conjugated hyperbilirubinemia of infancy, because the later term is actually better, because cholestasis actually signifies a more biochemical and a histological term, and conjugated hyperbilirubinemia, if we use that, it can include all the etiologies in it. But preferably it should be both these terms. Whenever you are using, you should use it up to 6 months of life. But sometimes in our scenario also, like in our country, sometimes they have history right from means the babies start developing jaundice by around 2.5 months of age, but the patients ignore it and they came to us by 9 months of age. So then also the same syndrome should be labeled, either whether you call neonatal or infantile cholestasis.
Thank you, sir. So the next question comes all the way from Pune. Dr. Snehvardhan asks that in cases in which you have strong suspicion of genetic cholestatic disorders like PFIC, etc., would you suggest doing a genetic mutation testing without a prior liver biopsy?
This question is also important, especially in the Western world. What they are doing, I remember, and possibly some of the other people may also agree with me that in most of the centers outside India, they now actually rely more on the genetic test rather than on the histology. So if there is a strong suspicion, but as we know that biliary atresia is the commonest cause of cholestasis still in India or in the Western world. So this disorder should not be excluded. And we see that there are fallacies at every point. Ultrasound and means like and ultrasound, or even the biochemical test like GGT and other things. So that's why, because every test may be fallacious. So that's why the histology is important. Histology has a 95% accuracy for biliary atresia. So in order to not to miss biliary atresia, so that's why I can suggest that the liver biopsy, liver histology should be done. because there is no other way. Genetic test, if you send also, it will come in a month time. You may miss the biliary atresia, the opportunity to get him operated if he is biliary atresia.
Yes, sir. Another question, the person has not identified himself. His question is there a maximum age beyond which the surgery for biliary atresia is not effective?
Yeah, maximum age, specific age, I cannot mention, because we have seen babies, means at even at our center, and those who have been operated from other centers also beyond 120 or 130 days of age, means you can so that also is if you are taking up an infant for surgery, means if he is a confirmed biliary atresia, so then certain things you can look for, like in the laboratory parameters, you can look for his albumin. So if the albumin is decreasing, so that means he is having significant synthetic dysfunction has already set in. So this baby is likely to decompensate after the Kasai potentoscopy, and most likely he has his liver has already progressed towards cirrhosis. Other thing is, you can also get like non-invasive, in the non-invasive marker you can do fibroscan. So if the fibroscan values are high, normally for biliary atresia, if they are picked up very early, the values are around 10, 12. So if the value is going beyond 25, 30, so then possibly the liver is almost cirrhotic, and the things may not reverse back after the Kasai potentoscopy. So, but a specific age, like from the King's College also, there is a big series. So where Mark Davenport has reported that even beyond 100 days of age, they have reported that even the outcome is not that poor.
So I think we can summarize. Uh, uh, it's never too late for doing a Kasai portoenteroscopy for biliary atresia, provided it doesn't have any synthetic failure or any advanced fibrosis.
Yeah.
Sir, the next question is from Devansh, Dr. Devansh. He says, what's the logic behind triangular cord sign for biliary atresia?
Yeah, the logic is simple, because the CBD and the whole tree is atretic. So whole biliary tree is atretic. It is like a cord. There is no lumen in it. So but that is so CBD. If you look up the lower part of the CBD on ultrasound, that is actually difficult to make out. But at the level of porta, you can actually make out CBD in a normal infant. So at the level of porta, if you try to locate CBD, so that CBD is not visualized, and that is like a cord like, and which is actually interpreted as a triangular cord sign. So the dimension of that triangular cord is also mentioned, that it should be the width should be more than 4. So if it is more than 4 mm, so that is actually suggestive of a positive triangular cord sign. But that also depends on observer's experience. So you have a very good trained radiologist who has the experience of looking up the neonates to see that triangular cord sign. In our experience, it is more easy to look for gallbladder size. First thing is to look for the gallbladder, whether it is visible. If it is absent, then it is almost means almost synonymous with biliary atresia. And if it is visible, but it has a dimension which is less than 19 mm, or some studies say less than 15 mm. If it is a small, and also look for the wall of the gallbladder. If it has a ghost wall, like the mucosa is like irregular, which is also called as ghost gallbladder. So if that thing is there, so that is actually more suggestive of biliary atresia.
So this is a question anonymous listener. He asked that can we differentiate clinically between a case of a PFIC and a bile acid synthetic defect?
Yeah, for PFIC and bile acid synthetic defects, the simple thing is, if you can look for the serum bile acids. But serum bile acids should be sent before starting these babies on ursodeoxycholic acid, because if you give ursodeoxycholic acid, so then fallaciously the serum bile acids may come out to be high. So if the baby has not received any ursodeoxycholic acid for at least 1 week, so then you can send for serum bile acids. So for bile acid synthetic defect, the levels will come out definitely to be low, but in PFICs the levels will be high. This is just like a screening test. For confirmation, you have to do for the genetic testing.
I would request the listeners to mention their names if possible. So the next question is another from an anonymous listener. He or she asked that what is the role of fibroscan in the diagnosis of neonatal liver diseases?
Yeah, fibroscan actually we have also done, means in our cohort. So we have seen that for biliary atresia, basic thing is whether you can differentiate biliary atresia from non-biliary atresia, because other etiologies of liver disease may not have significant fibrosis if you pick up within 2 months or 3 months of age. Excluding some of the etiologies like neonatal hemochromatosis, which can present within first week of life with cirrhosis. So that group, if you exclude that group, so you will be left with biliary atresia versus PFIC or some late presentations of MLDs. So what we have seen, like biliary atresia, so they have usually the fibroscan levels are more than 9.5 or 10. Whereas other etiologies, other PFICs or idiopathic or other infections, metabolic liver disease, they have lower values of fibroscan. So, and another study which has been published, so they actually mentioned a cutoff of around 7.5 something. Above 7.5, it is biliary atresia, and below 7.5, non-biliary atresia.
Sir, I've already seen that the most common investigations which a non-pediatric gastroenterologist or hepatologist writes while investigating a patient of Cholestasis syndrome is, along with a liver function test, the most common profile, the test mentioned is a torch profile and a HIDA scan. Can you re-emphasize to everyone what is the exact indications in which these tests should be?
Yeah. This is the slide. Can you see this slide?
Yes, sir.
Yeah, so this slide was mentioned from the first presentation, where the presentation was typically biliary atresia. So in this scenario we should be look for torch. We should never send for the torch. And among the torch also, the only thing which is actually known to cause some like hepatitis or neonatal cholestasis like picture is CMV. There is no need to send the other profiles like rubella or herpes and other things. Herpes, if it causes neonatal cholestasis, it is actually a neonatal liver failure which presents within first week of life, and then the patient is very sick, and he has most of the babies have actually multi-organ dysfunction syndrome, and so these babies are usually very sick. That presentation is entirely different, so no need to look for other things, herpes and everything else. So for CMV, so I will focus on CMV now. So whether we should look for CMV or not. So CMV, most of the time CMV is actually a bystander. So unless and until if you are seeing other extra hepatic presentation of CMV, like there is a myriad of other presentation. So the baby should have microcephaly on ultrasound calcifications, or there may be some thrombocytopenia, some rash or something else, and the baby will be IUGR. So if all other things are present, so then you can screen for CMV, and that may be an indication to treat CMV. We have seen babies who present with neonatal cholestasis. Sometimes they have biliary atresia, so they have CMV as a bystander, and even if you leave their CMV, means leave CMV as such, so then also their CMV status will improve gradually with time. So only in a particular scenario, I would like to emphasize again that when there is conglomeration of features to suggest congenital CMV, then only you should screen for CMV. Otherwise, you may just be dealing with just as a bystander CMV.
Yes, sir. So this next question, also from an anonymous listener. He or she asked that what's the 5-year survival rate after Kasai photoenterostomy in a compensated cirrhotic, and also what is the rate or reversal of fibrosis in such cases?
Yeah, actually, this is means you are talking about the natural history of biliary atresia who have actually successful Kasai photoenterostomy. So if the baby is the most important thing is whether the baby has successful Kasai photoenterostomy, which depends on whether the bilirubin has come down below 2 or like like some people take as below 1 milligram per deciliter or below 20 millimole per liter of bilirubin. When it comes down below below this level, within first 6 months of life. So if this is a successful Kasai, so for successful Kasai, the outcome actually depends on the subsequent events which the patient may suffer. So subsequent events which the patients may suffer most commonly, which we have also analyzed, that the most common events which they have is recurrent cholangitis. So even a single or two episodes of cholangitis may severely affect the successful Kasai potantrostomy. So when these livers suffer episodes of cholangitis, so these livers rapidly progress towards fibrosis. They have portal hypertension, and subsequently they have portal hypertension related complications. So if you specifically ask again for the 5-year survival, we should actually start from the starting point. Means if we take 100 infants, 60%, 60 to 70% may have a successful Kasai, and out of these successful Kasai, that means I can say that depends. The subsequent course will depend on whether they have recurrent cholangitis or no cholangitis. So no cholangitis is relatively less common. Most of the babies, around 70 to 80%, suffer from cholangitis episodes. So therefore it is important to give them, to treat the cholangitis episodes appropriately, and also to put these children on prophylactic antibiotics. What we are doing is we give them cyclic antibiotics for a period ranging from 1 to 2 years. So that is a bit long, which other centers are not actually doing. So, but what we are seeing, that those children who remain on long-term prophylactic antibiotics, so they actually are doing better.
Sir, and especially especially asked if the patient had, say, compensated cirrhosis at the baseline.
Yeah.
How does history after Kasai surgery changes, say, at 5 years?
Yeah, if the baby is surviving at 5 years, I will say that the initial cirrhosis part at Kasai potantrostomy may have actually reversed, but the subsequently, actually, if you see the long term, means 5 or 10 years, so then even if you ask for 5 years, if the baby has not suffered any cholangitis episode, and if the feel of the liver is soft, which most of the time it is not there, and if spleen is also not palpable or it is very small spleen, I can say that means the baby's natural history will remain okay for quite some time. But eventually, if you ask that what will happen after at the age of 10 years or 15 years, so then around 80%, 70 to 80% of these even successful Kasai potantrostomy babies, by adolescence or by 15 or 20 years of age, they eventually need transplant for various indications, like they may have sometimes portal hypertensive complications or hepatopulmonary syndrome or something else.
So next question comes from Dr. Shri sir from Lucknow. He's asking, is there any cutoff age you would like to say where we can safely recommend Kasai for biliary atresia, and after which LT should be thought of?
Yeah, yes, sir. So this is the same question which was asked earlier also, at what age, up till what age we should consider for Kasai, and after that we should directly consider for liver transplantation. I can say that liver transplantation at 3 months may be even more difficult. Possibly in future, when the liver transplant surgery and other things will actually become more technically advanced, so then the things may change in future. But in the present scenario, I can still say if the liver synthetic functions are normal, if the albumin is around 3.5, and if the liver clinically is not that hard, and spleen is not very big, that means that liver fibrosis is not that much advanced, and portal hypertension is not that much severe. So then the babies still may be considered for Kasai potantrostomy.
Sir, another question from sir only. Sir is asking that in this lockdown period, what advice you are giving to parents of children with neonatal cholestasis who are not able to come for follow-up?
Uh, it means specifically this is means overall for neonatal cholestasis babies.
Yes, sir,
Yeah.
especially since in this lockdown, they are not even able to come physically for follow-ups.
Yeah, means this is actually because neonatal cholestasis babies have a varied group of etiologies. So this may depend on so what etiology actually they are having. So like for biliary atresia who are operated, so they may also need actually what is happening to their liver functions. They may need test every 2 weeks or 3 weeks. But in contrast to other etiologies like for PFIC or for metabolic liver diseases, so some of these etiologies may also require repeated testing just to see where are their liver synthetic functions going. So uh, means if their synthetic functions are improving, or if for a biliary atresia bilirubin is going down, so that means, but testing definitely is indicated. Testing is which they can do at their local lab.
So next question is also from an anonymous listener. He or she is asking, so what is the current role of genome-wide association studies or whole genome sequencing in neonatal cholestasis, and what are its implications in the management?
Yeah, like genome sequencing. So these tests should be indicated only in a specific cohort of patients, not for each and everyone. We should actually send for the genome sequencing. Like most of the disorders, you can diagnose just by simple biochemical and other tests. Even like galactosemia and tyrosinemia, so these can be diagnosed by biochemical tests only. But if you are suspecting certain other genetic cholesterol type 1, type 2, or TJP2 or FXR mutation, so then these testing may be indicated. Or like so these tests also should be individualized. So like I already mentioned the flow chart for the investigation for neonatal cholestasis in this presentation only. So like this one. So here, the common disorder should be excluded first, which can be excluded on the basis of simple biochemical and imaging-based tests. But if you are suspecting the genetic cholestasis or certain rare forms of metabolic liver diseases like Niemann-Pick type C or sometimes Wallmann's or some other disorders, so then the genetic testing is indicated.
So the next is in what scenarios do you see HLH in neonates?
Yeah, HLH in neonates we have seen. Yeah. Yeah, HLH in neonates we have seen. So, but that presentation is like sometimes like we have seen one baby who presented as neonatal liver failure who had a dengue, and subsequently he had HLH like presentation. He had some cytopenias and then he improved. So that presentation, that is like a secondary HLS, secondary to dengue hemorrhagic fever. Other presentation is like a congenital HLH, but in that scenario, the babies may have very mild bilirubin, but they may have other presentation, like uh, they may have mild coagulopathy, but they may present with other organ dysfunction, because that is actually an infiltrative disease. So congenital or familial HLH, so the presentation can be varied, but it may be yeah, it can be it can involve other organs apart from the liver, so it may be a multi-organ dysfunction like presentation.
There's another question about thoughts on neonatal cholestasis that I think we have already discussed. And another
Yeah.
question is from an anonymous listener. In what scenario do we treat CMV and CMV, IgM, and IgG? And I think he or she is asking, maybe trying to ask about the cutoff levels, or if there is a positivity or negativity. In what scenario do we treat a positive CMV, IgM, and IgG?
Yeah, so positive IgG does not need any treatment if it is just isolated IgG positivity. So, but because that indicates that the antibodies have been transferred from the mother, so that if IgG only is positive. So, but if IgM is positive, IgM CMV is positive. So, as I already mentioned, that IgM CMV, again you have to look for the CMV PCR in the blood or in the urine, or the best will be in the urine. So you have to look for the CMV in the urine or in the blood. So if the CMV PCR is positive, and but if the baby is having other features to suggest a congenital CMV, so then the patient may need treatment. Particularly, I am talking specifically the scenario of neonatal cholestasis. So the CMV has varied presentation. So as I already mentioned, all neonatal cholestasis babies should not be actually looked up for CMV, because CMV in most of the babies is just a bystander. It may just go away on its own. So no need to treat all the CMVs in the setting of neonatal cholestasis.
Yes, sir. So Dr. Vineet Tomar has again asked one question, that is there any confirmatory test to diagnose neonatal hepatitis?
Yeah, like neonatal hepatitis. Are you asking neonatal hepatitis?
Hepatitis, yes, sir.
Yeah, so neonatal hepatitis is a broad term which was used in the older days. So in the older days, the issue was to differentiate biliary atresia from neonatal hepatitis. So neonatal hepatitis, whatever other etiologies were coming into the picture, I will show that slide. So that all was called as neonatal hepatitis. So this, if you can see, so the 25% were biliary atresia, and all other etiologies were actually called labeled as neonatal hepatitis, whether it was syndromic like some PFIC, some alpha-1 antitrypsin deficiency, or some TORCH. They were all labeled as neonatal hepatitis, and they used to differentiate on the basis of like these neonatal hepatitis babies were actually more sick. They had failure to thrive. They were not growing well. So because they have actually more of them were actually having some inherited metabolic disorder. So that's why they did not fare well. In contrast to biliary atresia, earlier they did not have any growth failure in the first 2-3 months, and subsequently they start having manifesting themselves with firm liver, hepatomegaly, splenomegaly, and subsequent decomposition. So neonatal hepatitis, if you ask me, so this is actually now an obsolete term. We should actually, because now in the present scientific world, we should use specific terminologies like whether the baby is having familial cholestasis, PFIC, or if the patient is having ductal paucity, that is Alagille syndrome, or if the patient is having TORCH, or if the patient is having metabolic disorders. So that was an older and obsolete term.
So I don't think there are any more questions. So maybe we can, if Dr. Kunal agrees, we can wind up this session. I think I can hand over to Dr. Kunal now.
Yes. Thank you very much. Thank you, Dr. Rajiv Khanna, for a lucid, well-informative and case-based. This is, I may say that not the webinar, but the in-clinic presentation at the bedside. You have taken the live case presentation to all of us. Thank you very much.
Thank you.
Is there one? Do we have 1 minute for another last question?
Yes,
question
please.
just popped up.
Yeah.
Please.
Sir, the question is: mother is lupus positive and receives immunosuppression therapy, and child has conjugated hyperbilirubinemia with pancytopenia in a preterm baby. What should I think I'm trying to understand the question. What should be the cause in such a scenario? Should we label it as sepsis, or it is because of the immunosuppression, or is it because of the lupus positivity the mother is having?
Yeah, this may be, these are actually the causes which you are thinking already. So this may be like because sometimes they may have immunological, so this baby is having cytopenias.
Yes, sir. Pancytopenia.
Yeah. So cytopenias can be sometimes like they may have autoimmune hemolysis, they may have autoimmune thrombocytopenia because of the maternal antibodies. So anemia and thrombocytopenia can be explained by that. But I am not sure about the leukopenia what the baby is having. So, but immunosuppression. So the things which you are thinking, so that are you are right actually. But subsequent tests, the baby may need. Then only you would be able to differentiate. But first thing I will label as possibly this may be some autoimmune phenomena which babies may be having from the maternal autoantibodies.
I think there is one last question that's coming from PGI Chandigarh from Dr. Babulal Meena. He is asking, what's your view on the upcoming role of phenylbutyrate therapy in PFIC-like disorders?
Yeah, you are asking phenylbutyrate.
Yes, sir.
Yeah, phenylbutyrate. Yeah, I am not sure about phenylbutyrate. Means that I am not sure. Means yeah, can you answer this question, Vikrant?
So phenylbutyrate therapies are still upcoming. There are trials which are going on both in all the genetic cholestatic disorders, not just PFICs, which are these therapies are being used. But I don't think anyone is currently using them in clinical practice as of now. So I'm not sure because we haven't used it, and I'm not sure if anybody I've seen using in US or UK anywhere. So I'm not sure what's the role, especially in this sort of. But these drugs which are being used, which cater to different pathophysiological mechanisms, they are the future because currently we do not have any treatment for these PFIC-like disorders other than giving them a simple ursodeoxycholic acid. So these drugs are coming up in future, most likely to prevent them from going ahead with liver transplant. These medications would hold key to future treatments.
Yeah, like there are other new drugs like obeticholic acid and other things, which also theoretically they may actually benefit in biliary atresia and PFIC, and also the toro also.
Yes, sir. No,
Acid. So theoretically, yeah, nor also deoxycholic acid. So these are certain drugs in the pipeline which may actually help.
Yes, sir. Sir, if there is a time, one last question: is there any role of EBV infection in neonatal cholestasis, and any role of antivirals?
Yeah, EBV actually, because that is not actually a common etiology of neonatal cholestasis, because most of these babies they get the antibodies from their mothers because the mothers already have suffered from, means they have naturally acquired EBV and they have antibodies, and these babies have actually antibodies against the EBV. So there is no role to routinely test these newborns for EBV PCR or even to treat. Means I don't know why actually someone looks for EBV in these babies. CMV is definitely, CMV is there is controversy about CMV but not about EBV.
So I think finally we do not have any further questions. So I'll hand over the proceedings to Dr. Kunal.
Yes. Thank you very much once again, Dr. Rajiv Khanna sir. Very lucid and nice presentation. As you have
thanks Dr. Kunal.
And,
Thanks, Dr.
during this lockdown, the webinar and the online seminars have made us to use this time. And I understand that you are very much busy in managing your day-to-day patients during COVID-19 pandemic. And it is a more responsibility of yours to guide the faculties across the country and across the world as we are on the webinar. IAP has given the guidelines on neonatal jaundice. In 2014 onwards, the doctors are practicing it. And the tertiary care referral, the centers like IL and BS is very important, and rightly referring to you is matters a lot, because liver and biliary disorder centers are managing it very effectively with the prompt diagnosis. So when it matters to the pediatric health, it's very important, and Panacea Biotech is always there with the hepatologist and liver and biliary disease centers. We have supported the liver disease patients, for example, Wilson's disease, as Panacea Biotech is connected with each and every hepatology center across the country with you to manage Wilson's disease patient. We have seen that the not only the academic support but supply of medicine and timely distribution of the drug to each and every patient in patients like Wilson's disease is life-saving. During the
Yeah, we
acute
are.
shortage for technical reasons, we have seen that how the Wilson's disease, if drugs are not available, life-threatening, it has been turned into life-threatening condition. During this lockdown, before and when the uncertainty of lockdown was there, lot of questions and contacts and phone calls have come to us that what will happen this time to the supply of thilamine, and we have ensured, and now also our each and every salesperson is visiting to the home of the patient, those who are communicating with us through you all and the hepatology centers, or directly to us through Facebook and social media. We are taken this responsibility to supply thilamine to each and every patient. Thank you very much for trusting
Yeah,
all
that.
hepatologists to us, and we are
Yeah,
always
we.
there with you, sir.
Yeah, we
And
are well
Dr.
aware.
Vikrant Sood, thank you very much
Thank
for
you.
moderating these sessions very nicely and taking each and every question of the participants. And I know that many questions and the doctors, those who have asked, you know them by the way the questions they are putting in. That's
Yes.
great.
Yeah,
Thank you very
yeah,
much on
doc-
behalf of Panisha Biotech once again, sir. And I want
yeah.
that
Thank you.
concluding note from you.
Yeah, thanks, Dr. Kunal, and we really appreciate your efforts for the patients which you are putting forward, because we are aware that many patients have limited shortage of D-penicillamine, and you are going to every place, means not necessarily in North India, every part of the country you are going them, where from wherever the patients are contacting you, you are providing the drug. So because this is actually a means this is actually an essential drug, and all the chemists do usually do not have this drug, so they are actually getting the drug from you only. So I really appreciate efforts of Panacea Biotech. Thank you, thanks a lot.
Thank you very much, sir. And we conclude this session here.
Thank you.
Yeah, we can log off.